We are live, please.
So, good evening. Welcome to the fourth and the final episode of the webinar on refraction. The basics of refractive surgery and LVA will be covered in the last segment today. And for that, we have Dr. Sheetal Savur, who is the professor and head at the Ennopoya Medical College, Bangalore, Karnataka, who will be covering some of the very basics of refraction, which are important for refractive surgery and the low vision aids management. And for that, we have our co-chairperson, Dr. Meghna Patil, who is a cornea phaco-refractive specialist, who is also a professor at the JGMMC Medical College at Hubli, Karnataka. And Dr. Namrata Sharma, who of course needs no introduction, and the Chairman Scientific Committee of AIOSSC will be joining us soon on this webinar. And this idea of Dr. Namrata Sharma to have a 4-episode webinar series on refraction. It has met with a lot of success. We have a lot of hits. A lot of people have joined us on the web for the last 3 episodes. And she's also planning to make this like a course, an accreditation course on refraction. So thank you, Dr. Namrata, for the same. And over to Dr. Meghna Patil, who will be co-chairing this session for her brief remarks.
Good evening all. I'm Dr. Meghna Patil. I'm Associate Professor in Department of Ophthalmology from KLE JJM Medical College. Today, Sheetal ma'am will be speaking about refractive surgery and LVA. As we know, the refractive surgery has made remarkable progress from simple basic LASIK to Calyx platforms. So then we have low vision aids. So ma'am will be briefing us about the basics and the low visions. Thank you.
Okay. Before Dr. Sheetal starts, refraction, of course, is the bread and butter of ophthalmologists, and some idea about refraction is required in every subspecialty, and more so in the refractive surgery. As Dr. Meghna alluded, refractive surgery has taken the center stage. We have a huge population in India and a huge backlog on the load of refractive surgery.
Yes.
And to see the numbers of refractive surgery happening in today, it's quite pathetic. We have a huge, an opportunity for ophthalmologists to really think of refractive surgery as the solution for many of the problems faced by all ages population. And the
Yes.
low vision aids a very neglected part of the
Yes.
our treatment, I should say. A
Very
lot
true.
of times we cannot improve the patient's vision with any kind of modality of surgical or medical management. And improving the patient's quality of life by giving or providing a low vision aid which can really help the patient to see better and to have a better quality of life.
Yes.
That is where the some of the refraction tenets lie. So
Yes.
to cover these two very important aspects and an extremely practical part of our
Yes.
day-to-day management, over to Dr. Sheetal Savur for her talk on basics of refraction for refractive surgery and low vision aids. Over to you, Dr. Sheetal.
Thank you, Dr. Krishna Prasad, sir. And with the permission of the chairperson, I would straight away start my presentation. Okay. So now we come to the last part of these series, and it's very interesting. Like Sir said, the burden of diffractive errors and particularly myopia is increasing. So I think it becomes extremely pertinent to have this topic. And my task is actually not very easy because I believe that simplicity is the ultimate form of sophistication. So I'm trying to keep it simple and yet be sophisticated. So, myopes, if you are one, you would have realized that you would have faced so many problems, right? Your world is small. It's a minified world. And quality of life is also poor because many a times the myopes are restricted to indoors. They're more reading books than playing outside. They have a cosmetic blemish. You might have known that people are calling you chashmish because you can't do without those glasses. You're dependent on it. And yet at the same time, you don't feel happy that you have to wear it all the time with people teasing you sometimes. And the field of vision is also limited. And many times the financial burden, especially there are people who are willing to spend thousands on their glasses, 10,000, 15,000. A couple of spectacles will perhaps be more expensive than undergoing a refractive surgery. Also, so many times fogging of glasses becomes very, very irritating. Small things, but on a day-to-day basis, they really bring down the quality of life of patients. So the burden is huge, and it is expected that by 2050, almost 50% of the world's population could be affected by myopia. And this is more so in East and Southeast Asia, where they say up to 80 to 90% of young adults are myope. So the burden is huge, which also means that it's good news for ophthalmologists. They have a lot of work to do. You're in the right place at the right time. Okay, getting back to absolute basics. So we'll start with the dioptric power of the eye, which is around 60 diopters. And most of it, or 2/3 of it, is contributed to by the cornea. And the remaining 20 to 25%, around 20 diopters, is contributed to by the crystalline lens. So it is imperative that cornea-based refractive surgeries are going to play a major role. Or as of now, they do play a major role. So how do cornea-based refractive surgeries work? So in myopia, the eye is overpowered. The central cornea is curved, and therefore we flatten the central cornea, bring down the power of the cornea and also the dioptric power of the eye. The opposite happens in hyperopia. So the power of the eye is relatively less. So we are going to steepen the central cornea and try to increase the dioptric power of the eye. And then comes the change in the meridional profile. And that is how we are going to correct the astigmatism. So how do we sculpt this cornea? Cornea is such a delicate structure. So we need to use a very fine beam to create the shape that we wish to. And by changing the shape of the cornea, we are going to change the dioptric power of the cornea and that of the eye. So there's always a price to pay or always a trade-off. So we may sculpt the cornea and get the refractive error right. But remember, the cornea is never going to be the same again. There is going to be some kind of a permanent alteration. There is going to be a change in the biomechanics, and this will affect the long-term stability and also safety. The other price to pay is with the poor quality of vision. So we have added aberrations, mainly the higher order aberrations after the procedure. And the healing is not normal. So it may result in some amount of scarring or interface problems. And there could be risk of infections. And also loss of contrast, which is quite common. So these are some of the problems that could arise. So that is the trade-off. Now, like in biochemistry, we have studied, there are some rate limiting steps, isn't it, in biochemical reactions. So similarly, in cornea-based refractive surgeries, the corneal thickness is the most important limiting factor. So since myopia is so much more common, obviously the most commonly performed keratorefractive procedure is for myopia. And as I mentioned earlier, the central corneal curvature is more. So we want to flatten it and thereby reduce the power. And for flattening, we are going to use lasers. Remember, it is easy to flatten the cornea than to steepen it. Okay, we decided we want to flatten it. But how much do we ablate to flatten it? So obviously, this depends on how much of refractive error or how much of myopia is there. So how much we ablate will finally determine what will be the final dioptric correction of the eye. So we have the Muller-Lens formula, wherein the ablation depth in micrometers is equal to the square of the optical zone in micrometers multiplied by the refractive error divided by 3. So this is mainly for tissue ablation, which we use for myopic laser refractive surgery like PRK and LASIK. So here's something to remember, that not every machine is the same. Therefore, the amount of cornea that has to be ablated to correct one diopter of refractive error is specified for each machine. Therefore, it must be calculated separately for each machine. Some more caveats. So, the formula tends to underestimate the depth of ablation. And especially so, this is when the optical zones are wider or the refractive errors are higher. But actually, when it comes to the machine ablating, it may ablate more or deeper than what is predicted. And therefore, the risk of post-operative corneal ectasia may be more. So remember, the formula can underestimate, but when it actually ablates, it could ablate more. Okay, so primarily, the cornea-based surgeries are of 3 types. Surface ablation, wherein you stun the epithelium with alcohol and then ablate the corneal stroma, and you can replace back the epithelium or it grows over. The other type is the making a flap. So you create a flap with a microkeratome or a laser, and after that, this flap is hinged. Then you ablate the stroma with either excimer laser or femtosecond laser, and then reposit the flap back. So here, lesser amount of corneal stroma will be available for correction as compared to surface ablation. And then finally, the lenticule extraction, wherein we are going to fashion a lenticule from the corneal stroma, okay, without making a hinge, and then make a small incision and remove this lenticle which we have planned according to refractive error. So here, the advantage is we are not going to damage the cornea, the corneal nerves, etc. Okay, let's try to understand this a little bit more by taking this example. Now, you are a postgraduate in ophthalmology. So your school friend decides to ask you. He says that I have 5 diopters of myopia. And because he's always heard the word LASIK, he says, if I undergo LASIK, will my power go away? So before you can give them an answer, you got to think of 3 important things. Like I said, most important is the corneal thickness. Next comes the size of the pupil, the mesopic pupil and the scotopic pupil. Scotopic pupil is the size of the pupil in the dark. So you want to know how much it dilates in dim illumination. And finally, you want to know how much of cornea to ablate for that amount of refractive error. So you're going to use the Muller-Lens formula, and you're going to know which specific one you have to use for the machine that you have. Okay. So in this case, let's assume the thickness of the cornea is 530 microns. It's fairly thick. So if we make a flap for LASIK, it usually takes up about 130 microns. So if we subtract 130 from 530 microns, we are left with 400 microns of stroma available for ablation. Now, this particular machine ablates 12 microns to correct a 1 diopter of refractive error. So if we have to correct 5 diopters of refractive error, you multiply 5 by 12. So 60 microns has to be ablated to correct 5 diopters. So out of the 400 that was there, now we have ablated 60 microns. So how much is remaining? 340 microns of residual stromal thickness. Now this is very important. This is a simple image to show you. 530 is the total thickness of the cornea. So the flap on top is the flap, 130 microns. 60 microns is how much is ablated, and the lowermost portion is the residual stromal bed. So it's good to have residual stromal bed which is more than 300 microns. Between 300 to 275 is somewhat okay, but if it is less than 50, it's going to be a problem for the patient. So it's relatively unacceptable. So now you're in a position to tell your friend that you can go ahead with the LASIK. You will be completely free of your glasses. So you're giving your friend a green signal. Now let's consider the second example. So this young gentleman is an aspirant to join the army. Now he has a refractive error of -10 diopters. He's a myope and he wants to have normal vision, 6/6 vision without glasses. So let's see if he's a suitable candidate. So you measure his corneal thickness, it's 500 microns. Okay. So if we subtract the flap thickness, that is 130 microns from 500, we have 370 microns of corneal stroma available for ablation. Now, if this machine corrects 12 microns if 12 microns of ablation is required to correct 1 diopter of refractive error, then we need to ablate 120 microns to correct 10 diopters. So from 370 microns, which was available to us, if we subtract 120 microns, we are left with 250 microns only of residual stromal thickness. So as I mentioned earlier, this is not exactly a good state to be in. Okay. So now remember the Monalins formula and the optic zone has a very important relation there, isn't it? So for a 6.3 millimeter optic zone, an ablation of 12 microns will correct 1 diopter of refractive error. Now, if you reduce the optic zone to 5.7 mm, then lesser amount of cornea, that is only 10 microns, needs to be ablated to correct 1 diopter of refractive error. So instead of the 120 microns that we previously calculated, we need to ablate less, that is 10 into 10, only 100 microns now to correct the same amount of refractive error. In the process, we are saving 20 microns of corneal tissue. So that leaves us with a 270 micron of residual bed. So 270 is okay, it is not so bad. Perhaps we could consider the procedure. Now we are getting more enthusiastic. So we want to save more cornea, isn't it? So we'll say, okay, why not try this 5.5 mm optic zone? We can save more cornea. So 8 to 9 microns itself is enough to correct a 1 diopter refractive error. So the point to remember here is when we reduce the size of the treatment zone, we are saving more of the cornea. However, there is always some price to pay. And in this case, it's going to be the limiting factor is the pupil zone. So if the pupil dilates to 6 millimeters, and our treatment zone was 5.5 millimeters because we got very enthusiastic in saving the cornea, then what is going to happen? Photic phenomenon will set in. That means the patient can have glare and other photic phenomena. So optic zone should always be more than the size of the mesopic pupil. And that's why the size of the pupil matters in refractive surgery. So if the pupil is large, then small zone ablation will not be possible. So in that case, you may have to tell this gentleman that maybe a surface ablation like PRK or a trans PRK may be better because that is going to save us more stroma. There we only are going to make an epithelial flap of say 60 microns. So more of the tissue will be available for ablation. So now the concept is changing a bit. So what is important is not the absolute residual stromal thickness. As I mentioned, we said 250, 275, 300. But it is the percentage of the cornea ablated with respect to the total thickness of the cornea, that is important. Let's try and understand this with two examples. So in the first case, the corneal thickness is 600 microns. So if we ablate 50% of the cornea, it's going to give us 300 micron of the residual stromal bed. So this cornea, despite the cornea being 600 and the residual stromal bed being 300, is going to be at a greater risk of ectasia than the second case. So in this second case, the cornea is only 500 microns, but we are ablating only 30% here as against 50% in the previous case. So even though the residual stromal bed is only 150 microns, still this cornea is at a lesser risk of ectasia. So the percentage of ablation is more important than the absolute value of ablation due to its relation to the overall thickness of the cornea. What happens if you ablate more tissue? You will end up with more astigmatism, aberrations, and a future risk of ectasia. So what do you do if you have, myopes who are having very high power? How do we help them? So now we need to think of a change. We change to lens-based procedures. So commonly, phakic IOLs are used. So here we place a very thin Collamer lens between the iris and the anterior capsule with the natural crystalline lens in place. Now, what is the beauty of this procedure is the cornea is pristine. We don't meddle with the cornea at all. Remember, that is the one which is most responsible for maximum refraction and the quality of vision. So we are not going to touch it. And this procedure is reversible. You can remove this lens if required. And it corrects very high degree of refractive error, minus 15, minus 18, minus 20. So that's great for the patient. However, there is a small risk of endophthalmitis as it's an intraocular procedure. So that is something to understand and that is something to counsel the patient about. Coming to the next concept in refractive surgeries. Okay, the angle kappa and alpha. It's quite simple, though it sounds a bit daunting. It's quite simple. So the problem with refractive surgery is that the ablation has to be planned and centered around some visible landmark around the eye. So obviously, the visible landmark is the pupil, and this is what most machines are going to track. So if the center of the pupil is away from the center of the cornea and the visual axis, we are in trouble. It's going to result in a decentered ablation, and consequently, the patient is going to suffer from a lot of photic phenomena. So this is very simple diagram to show you what angle kappa is. So the red line is the line which joins the fixation point to the fovea. And the pupillary axis passes through the center of the pupil. Now between these two lies the angle kappa. So a large angle results from the difference between the corneal apex and the pupillary axis. So now what is the clinical relevance? In hypermetropia, especially larger powered hyperopes, the angle kappa is positive. So the gap is much more. Therefore, if we center the laser on the pupil instead of the visual axis, we'll get a decentered ablation. As you can see in this image, that the ablation is decentered. And as I mentioned earlier, the quality of vision is not going to be great because of the photic phenomenon. So either if it is very large, better to avoid LASIK, or now you have better algorithms, but we need to spend a lot of time to counsel the patient if this is acceptable to them. After surgery, there is no point in complaining. The other angle is the angle alpha, which is between the optical axis that passes through the center of the cornea, lens, etc., and the visual axis, which joins the object of regard to the fovea. Now, this is generally more useful in IOL centration. Okay. As much as we spoke about the benefits of refractive errors, there are some problems. Like we need to elevate a flap which consists of epithelium, Bowman superficial stroma. So what happens as a result of this? There may be scar, there may be flap-related problems, interface problems. We are cutting the corneal nerves, so dry eyes, and also there is a risk of infection. So what happens in the lenticule-based procedure is many of those problems are taken care of. The corneal biomechanics is much more stable because we are not making a flap like we did in LASIK. So this also has a lesser tendency for dry eye, and the eye or the cornea is much more stable. So we just remove the small lenticule and remove it through a small micro incision. So let us just try to understand lens-based refractive surgeries, because the cornea-based surgeries have limitations. You can't remove too much of it, otherwise you're going to compromise the biomechanics. So lens-based refractive surgeries primarily, as I did mention earlier, we add a lens to the already present crystalline lens, or we remove the crystalline lens and we replace it with an artificial lens. So phakic IOLs, who are the right candidates for it? So it is usually the young and high myopes. So young, because if we remove the crystalline lens in them, they are at a higher risk of developing retinal breaks. So it is always better to do a cornea-based, it is always better to preserve the lens in myopes. So we place the phakic IOL, as I mentioned, behind the iris and in front of the lens, and this preserves accommodation. So young myopes are ideal candidates. So in whom do we then remove the crystalline lens and replace with IOLs? These are typically the hypermetropes with presbyopia. So for example, let's say it's a person with +8 diopter of hypermetropia, who also has significant astigmatism and is also presbyopic. Now, there's no point leaving a dysfunctional lens in a refractive surgery. So, by removing the crystalline lens and replacing it with the toric trifocal, we are taking care of multiple things. We are correcting the hypermetropia, we are correcting the astigmatism, and also we are going to give him good near vision, which he had lost because of the presbyopia. So in future, perhaps this is going to become the surgery to look forward to correct problems when there is refractive error, especially hyperopia with presbyopia. Of course, this also does have its own set of problems. Like, for example, the sizing is very important. And if it is not appropriate, there could be vault-related issues. Then there is a risk of pupillary block glaucoma. It's very close to the anterior capsule of the lens and the crystalline lens. So there's always a risk of developing early cataract in them. And it could irritate the iris and give rise to iritis. So now that we have some idea that if a person has a high refractive error or a mild to moderate refractive error, what is the best way we can guide them? Is it surface ablation? Can we subject them to a flap-related surgery? Should we do a lenticule-based surgery? Or if it's very high, should we go in for lens-based surgery? I think now you have a fairly good idea. So just for completion, I would just like to touch upon the incisional surgeries of the cornea. Now, these used to be done in earlier days, and we no longer do them because we have much better procedures now. So what is the principle of this? Here, especially in myopia, what we are trying to do is, we are trying to flatten the central cornea, okay, and bring down the power of the eye by controlled radial cuts. As you can see in this image, the cuts may be anywhere between 4 to 32, always even in number. And you can see they're almost coming up to the pupillary area. So what is the problem with this? This can give rise to irregular astigmatism. So close to the pupil, photic phenomena are common. And not only that, these are very deep cuts. So it can always weaken the cornea and in future result in ectasia. Therefore, they are almost obsolete now. Next, coming to astigmatic keratotomies. So there is the arcuate keratotomy and limbal relaxing incision. Sometimes the LRIs are still done. So here again, it's a very, very simple concept. Okay. So we place the incision. Okay. It is in the shape of an arc. So it is placed along the steep meridian to flatten it. And what happens as a result of this is the meridian that is perpendicular to it becomes relatively steep. So let us see this example here. The vertical meridian is 46 diopters. It is steeper than the horizontal meridian, which is 44 diopters. So when we place an incision along the vertical meridian to flatten the vertical meridian, it becomes 45, and therefore the difference between the two also comes down, and this is called as the coupling effect. So one flattens and there is relative steepening of the other meridian. And you can also see in that image the depth of the incision is almost 80 to 90% there. The other incisional surgery here is the limbal relaxing incision. Now, peripheral incisions are always biomechanically better or stronger than the mid-peripheral arcuate incisions. So, and because these are away from the visual axis, they tend to cause relatively less photic phenomena. And these are still used during cataract surgery for correcting low to moderate corneal astigmatism. So these are the other two surgeries which are used to correct near vision, that is radiofrequency conductive keratoplasty and laser thermal keratoplasty. I'm sorry for that spelling mistake. I will again very briefly touch upon contact lens because it is extremely useful, especially in myopes. So let's try to understand why the myopes are going to benefit with contact lenses. So many times, these myopes may not be able to afford a refractive surgery, but we still want to give them a better quality of life. So it is still so much cheaper and the quality of vision they enjoy will be so much better. So I think it deserves a mention and a chance. So, contact lenses are placed on the cornea. There's a small gap here, but actually they are placed right on the cornea. So the vertex distance is 0. And because of that, it results in less minification. In other words, the image is more magnified when a myope uses contact lenses than using a concave spectacle lens. The spectacle lens, as you can see in this image, it is placed 12 to 14 millimeters away, and therefore it affects the vergence of the rays. And as a result, the image that is formed on the retina is much smaller. This is a very interesting thing and an important thing that one must know about myopia and contact lenses. Okay, so when the myopia is mild to moderate and we correct them with spectacle lenses, so we are giving them convex lenses, isn't it? So when the patient is trying to look at any near object, you can see that the spectacle acts as a base and prism for near. So what happens because of that? The patient needs to use less accommodation. So the spectacle has an advantage when it comes to accommodation and convergence in a myope. But this advantage is lost when they shift from spectacles to contact lenses, as we can see in this figure. On the right-hand side, you will see that the patient has to use more accommodation. Okay. And as a result, it could result in an exo shift and an accommodation lag when they change to contact lens. However, the advantages there is an advantage when it comes to hyperopia. Okay, because their glasses are base out prism. So when they shift to contact lens, they have an advantage because of the ESO shift and less accommodation lag. So the far point in myopes, remember, is close to the eye. Therefore, they don't have to use so much of accommodation for near, more so in case of higher degrees of myopia. Now, when we correct myopia and we make them emetropes, okay, with either spectacle lens or contact lens, they need to exert full accommodation when they want to see near. Okay. And because now the accommodation is hardly being used, they really need to use, they put a lot of effort and there is some amount of accommodation lag. They could be struggling with near vision. Therefore, always check near vision when you are correcting myopia. Now, contact lenses, as I again said earlier, increases both accommodative and convergence demand in myopia, and it's the reverse for hypermetropia. Now coming to the rigid gas permeable lens. Okay, let's try to understand very simple concept here. The refractive index of the tear film and the cornea are identical. Therefore, the anterior surface of the tear film replaces the anterior surface of the cornea in RGP. Now, what is the beauty of this is, this will neutralize so much of the corneal astigmatism. So, in high degrees of corneal astigmatism, remember, RGPs are going to give you very good quality of vision. So, let's look at this condition. Okay, so the refraction here is compound myopia. So, -2 diopters of myopia and a -2 cylinder at 180 degrees. Now, look at the K reading carefully. Okay, it says 44 diopters. That means there doesn't seem to be much of a corneal astigmatism. What is this condition and how do we correct it? Did you guess it? Okay, so this is a case of lenticular astigmatism. Why so? Because you can see that the cornea is spherical. Okay, it's 44 diopters. There's no corneal astigmatism, but there is lenticular astigmatism. Only spherical correction if we give, okay, it's not going to correct the lenticular astigmatism. So in this case, we would prefer a soft toric contact lens because the amount of astigmatism is not too high. We could go in for a soft and toric contact lens. If the astigmatism is higher, perhaps we may have to go in for a RGP. So this is just to show you that lesser amount of astigmatism can be corrected by soft contact lenses. Whereas if it is higher, we need toric RGPs. Now coming to the last part, and very interesting because I think this gets neglected and there is so much that an ophthalmologist can do to improve the quality of his patients who have low vision. I think in an OPD, at least 30 to 40% of patients have low vision, and very many times we think that when vision is less than 3 meters, if it's 2 meters, that is the time to go in for low vision aids. That is something I want you to primarily understand. That is not the time for low vision. Okay, then you have to rehabilitate the blind. Okay. So, what exactly is low vision? So, it is the best corrected visual acuity in the better eye. And by best corrected, it could be spectacle correction, contact lens, surgical correction, maybe medication. So whatever you try, if the best corrected visual acuity in the better eye is less than 6/18, visual field less than 10 degrees, then we call it visual impairment. In low vision, the visual function is affected, and this is going to affect the quality of life or the patient's activities of daily living. In low vision impairment, remember, there is always some useful sight. And vision is not just visual acuity. So there can be compromised contrast sensitivity, color vision abnormality, as well as reduced visual field. So when we assess for low vision, it's not very easy. First of all, many times patient is in denial, doesn't want to accept that he has low vision. Especially say it is 6/18 or vision like that, patient is going to deny it. More so because of the social stigma. So the kind of lenses, the low vision aids you see, they're not exactly, cosmetically very attractive. But it requires a lot of counseling to tell them that definitely they can have better quality of life if they adopt these low vision aids. So first of all, we need a thorough clinical evaluation because we want to know what is the cause of this visual impairment. So see if it is advanced POAG or ARMD. Then also do a functional evaluation. And I would really stress on this. You have to take a task-specific history. So you must know what is their daily activity, because it could be absolutely different for each one. What they want could be very different from what somebody else wants. So you can see some of these images and see what their priorities are. So these are all the difficulties. They may bump into other vehicles because they have peripheral field defects. They have inferior field defect. They will find it hard to climb stairs. So different ways their vision may be affected, and you got to know what problems they are facing and what exactly you want to help them with. So this is a detailed ophthalmic examination, including all these relevant tests. And for fields when the vision is low, sometimes you may have to resort to manual perimetry, Beerham's blisters, sometimes even confrontation. Okay. So let's try and understand what this low vision aid is. So it is any optical or a non-optical device that either improves or enhances residual vision by magnifying the image of the object at the level of retina. And there are 4 ways to do this. So you can increase the size of the object itself. You can change the distance, go closer so that it appears magnified. You could enhance the angular magnification and make the object appear big. Or you can use projection magnification. So this is an example where we use a large print so that you're enlarging the size of the object. Obviously, the size that is going to form on the retina is going to be large. Next is the relative distance magnification. So if you move closer to the object, or in this case, you bring the newspaper closer, then you can see it better. The letters are going to appear bigger. In angular magnification, we will use an optical device, such as a magnifying lens, and that is going to increase or enhance the visual angle and make the object appear bigger on the retina. So these are some of the low vision aids which use angular magnification. Let's look into this example to understand better. So Mr. X has best corrected visual acuity, distance visual acuity is 6/60. So he loves to watch TV, likes to watch sports. So that's what he does most of his day. Now, he needs 6/12 visual acuity to have a reasonable good vision to see the sporting activity on TV. So what is the magnification that he requires? So this is very simple. Whatever is the vision that he desires divided by the vision that he has currently, that is going to give you the amount of magnification. In this case, it will be 60 divided by 12, which is 5x. So he requires 5x magnification to watch his game on the TV. Now, there are different ways in which we could help him. So we can ask the person to move closer to the screen. So by reducing the distance, the object appears better. So there may be a myth that going too close to the TV is not good for the eyes. But this is what this gentleman has to do. If he wants to see better, maybe without using a magnifying glass. In the second example, you could increase the size. You see the size of the screen is huge and the contrast is also very good. And this gentleman is very close to the screen also. So maybe he can do without wearing telescopic glasses. In the image below, you can see that the person is using telescopic glasses to view the screen from a distance. So these are the different ways in which you can help solve the same problem by doing different. So we have different ways to magnify, right? You could mix and match and see which one is useful. let's take the second example. Here, Mr. Y or Miss Y has near vision, which is N18, and desires to see N6 because he or she loves to read the newspaper. So this Kestenbaum's rule again is this simple rule which tells you how much magnification is required. So you divide whatever is the present vision and divide it by whatever is the desired vision. So 18 by 6 gives us the amount of magnification. So that is 3x. Now at 25 centimeters, which we consider as the standard distance, one needs 4 diopters, that is 100 by 25. Okay. This will give you 1 unit of magnification. So if we want 3x magnification, then we have to multiply 3 into 4. That is, a person is going to require an add of 12 diopters at 25 centimeters to read N6. So if we give the person a high convex lens, a plus 12 lens as a near aid, which is going to give 3x magnification at 25 centimeters, then the person would have to hold the book very close to the eyes, 8.3 centimeters. Now, what's the problem with holding it very close? There's going to be a huge demand on accommodation and convergence. Now, that's not going to be very comfortable. So, we can help them by giving a relieving prism. That is, a base in prism has to be given. So, how do we know how much prism to give? It's very simple. So, whatever is the near add, you add 2 to it. Here we are giving if you're giving a 12 diopter add for near, you add 2 to it. So, we need to give a 14 prism diopters, and this is to be given in where we give binocular convex lenses. So this is just to show you that if we give high-powered spectacles, see how close one has to hold the reading material. So that is the compromise. Then we could also give them a stand or a hand magnifier. I'm going to just elaborate on it a little bit. So this hand magnifier, it's a very simple, common thing, easily available, cheap, convenient. But the only problem is you can't use it for a very long time. And especially if old people, they have tremors, arthritis, it becomes very difficult to use this. But however, it's useful and very simple. So this can be sorted by using a stand. So you continuously don't have to hold it. A person with tremors and all can still use it. Now, this has a fixed focus distance, and also you can see the part of it is open beneath. So that allows the light to go. So it becomes easy to read. It's illuminated. You also get the illuminated stand magnifiers. So as I was saying that these high plus lenses, they come in up to from 5 to 28 diopters. They require very close working distance. It's okay to read comfortably. Some people are okay with it. They can use it, but you can't walk and drive with it. So you are going to need something else if you want to have good distance vision. Okay. The other point I was mentioning is if you are going to give only a monocular high add, then okay, you can use up to 16 diopters. But binocular add, it is only limited up to 4.5 diopters you can give. And as I explained earlier, you need to add prisms to assist convergence and accommodation. So for example, if a person needs 8 diopters for near, and then you have to add 2 prism diopters to it. So the prescription will be 8 diopter sphere with 10 prism diopters base in. And this is for each eye you have to give separately. 10 for one eye and 10 for the other if the correction is similar. So loops, some of us have used it in OPD. So loop is a trade-off between these high-powered spectacles for near and the telescopes which are used for distance vision. So what is the benefit or advantage they give? So you're using spectacles mounted telescopes, but you're using them for near. So it gives you the magnification, yet you don't have to hold it very close to your eyes like you would do for spectacles. See, you can see here, the object is held at a fairly comfortable distance away from the eye. So it's a trade-off between these spectacle lenses and the telescopes. So telescopes are largely used for distance viewing. And here the concept is very simple. There are only two lenses. One is the objective and one is the eyepiece. The objective collects the light and the eyepiece magnifies the image. So primarily we use two types of telescopes here, and look at the word afocal. Look at the image. You can see that parallel rays of light are entering the system and parallel rays of light are exiting the system. They do not really come to any, they do not converge anywhere. That's why they're called as afocal systems. So the most common and practically used is the Galilean telescope. Why? Because it gives us an erect image. We see things as they are. And they're very compact. Why they're compact? You can see that the distance between the lenses is very less. Okay, because they're separated by the difference of their focal lengths. So it's easy to mount them on spectacles, and primarily they are used for mobility. They give more magnification. And remember, when the magnification is more, the amount of field is less. Think of a camera, and when you zoom it, you only see a larger portion of the object. You don't see the surrounding area as you increase the magnification. Now look at the Keplerian telescope. Here the two are separated by the addition of their focal length. So they are relatively further away from each other. So this telescope is bulkier. Okay. And the other thing is it gives you an inverted image. So this was used to see the stars. Concept of astronomical telescope. And did it matter how you saw the stars, inverted or erect? It didn't. But now we are using this and using mirrors or prism to reinvert the image so that we can get an erect image. The advantage of a Keplerian telescope is that the quality is better because it retains all the light. Light is not lost whatever enters the objective, unlike that in a Galilean telescope. So this is a bioptic telescope. In fact, in some countries, they do allow people to use this, it is allowed. So here you can see a small telescope is attached to his regular distance prescription. And they constantly do not use this. So when they drive, they use the lower part of the glasses. But when they want to see any directions or distance further away, so to spot something at a distance, intermittently they bend their head and look through the upper portion of the glasses where the telescope is there. So this is the monocular telescope. Again, it is supposedly used very commonly. It is high powered, gives a lot of magnification, but you have to keep on holding it. You can't use it continuously. It's used only for spotting. These are dome and bar magnifiers. So school children and all with visual impairment, they can use this. They are pretty convenient. And coming to the last part, that is field expanders. So there are conditions like ARMD where we have a central field effect, and then we have conditions like glaucoma and retinitis pigmentosa where we have peripheral field effect. So when there is a central field effect, a magnifier is used to enlarge the size of the object, so it stimulates the adjacent normal retina and one can see. So central expanders are largely utilized for reading. Whereas when there's a peripheral field effect, one uses a reverse telescope, and here the opposite principle works. You are trying to minify the image. Okay. And this helps in mobility. These are hemianopic prisms. They're also called as peliprisms. Okay. So they're used mainly for awareness of the fields. So the part of the field that is not visible is projected onto the part of the field that is seen. So remember, this is not for magnification, and this is placed on the same side as the field effect. So it basically moves the blind side info into the seen area. So you can see this image, yellow and black. So the black portion is projected onto the yellow seen portion. And then the periscopic prisms. So here the principle is very simple. The rays of light, as is seen in this image, the direction of line of sight is changed. So here we use prisms that change the direction of light by 90 degrees. Okay. So you can see this is how it is used. So the person is lying down and actually looking at the roof, but is able to view the book or even the TV screen, which is in front of them. So those on bed rest with neck or spine injuries, they benefit with these glasses. And sometimes, like the Gen Z, quite a few of them are lazy. They want to lie down and read. Even they can use, and they're called as lazy spectacles. So this was what I was mentioning, using minification for peripheral field enhancement. So in tunnel vision, what we do is we use a reverse telescope. So just reverse the normal telescope. Okay. And you will see that the field is double while the image is reduced in size. So you can see more in less amount of visual field that is available. And this is the last part wherein projection, that means the cameras in these CCTV based or video based, they are going to magnify the image and project it onto a screen. The advantage of this is that you can sit at a comfortable distance and read continuously. You can magnify the image as you want. You can play around with the contrast as you want, and also change the illumination. The non-optical aid is very simple. You can improve the lighting, change its focus, change the contrast, reduce the glare, and improve the quality of vision. So, lasers. So this is to conclude. Laser vision correction of refractive errors, particularly myopia, is the future. And soon, maybe it might be replaced by lens-based procedures, as even that is gaining momentum. For low vision aids, I would really request, please don't wait until the patients go blind. Maximize their visual function and improve their quality of life by suggesting to them, or you could prescribe it. You saw it's pretty simple to prescribe them low vision aids because small changes can make a big difference in their lives. So with this, I would, we can probably discuss more practical aspects of it. Dr. Krishna Prasad can take over and throw more light on this. Yeah.
Yeah. You can actually stop sharing, Dr. Sheetal. So an excellent exposition of all the refraction basics, very well told by Dr. Sheetal, both about refractive surgery and also on the low vision aids, which are very important. I think there can't be a better time than this because, as I told you, India has a huge myopic population, and somehow the young ophthalmologists are not very, what I should say, knowledgeable about the available refractive surgery procedures now. And many a times we do find a lot of postgraduates wearing spectacles themselves, not trying contact lenses in their earlier days or not planning for a laser vision correction. So that probably is a mindset problem because they probably have some kind of a phobia about what could go wrong in a refractive surgery. Because when such a mindset exists in today's future ophthalmologists or today's ophthalmologists, it's very difficult to convince the public about the usefulness of refractive surgery. I think the time has come to probably look at refractive error as a disease which has a solution, a very satisfactory solution at this point of time. See, what we have learned about the complications of various procedures, they have really evolved over time. And today's diagnostic ability, as well as the therapeutic competence and the gadgetry that we have, can definitely offer hope to majority of the patients with refractive errors. And it also makes a financial sense. People are wearing contact lenses, glasses, spending a lot of money, and they're living with it because the public at large is not educated about the advantages of refractive surgery. And the decision doesn't lie with the doctor and the patient. It is usually the parents, the society, and the overall the idea what people have about refractive surgery as a procedure. And people say it is okay to wear glasses without understanding the problems associated with it. I think there has to be a tipping point where a huge number of myopes undergo a refractive surgery and they make the consensus of the public. Dr. Meghna Patil, you are a refractive surgeon yourself. What do you think is the problem that faces a myope, an young myope? before embarking on a decision to get a refractive surgery done? What is the basic problem you think?
So first of all, I want to congratulate Sheetal ma'am. It was an excellent presentation and all the concepts were made very clearly. So basically what I feel is the awareness should start at the school level only. Because what we see many patients, even when they come around 18 years or 20 years, some amount of amblyopia is already set in. And when they ask us for all these refractive surgery options, they want full correction. Even though the with the spectacles, the vision is not clear. But the basic question what they ask is whether after undergoing surgery, I'll be able to see better than with the spectacles. At the awareness level only, there is a issue, sir. This is what is my feeling. Like,
I mean, awareness for the parents?
awareness for the parents, awareness for the kids also, and the kids, what you are the better person to tell it. At like 6 years is what we say amblyopia, and kids are not able to say what they are not able to see, and that is what is adding. And I feel that awareness programs has to be more for the parents or for the general public, that these are the options available, and that phobia, or I don't know what is there, that is not making them opt for refractive corrections.
I think it's also probably the fellow ophthalmologist, somebody who is not doing refractive surgery, or somebody who is not updated with the present technological advancements,
Yes.
may actually may not may be very encouraging to a young patient, a young myope, when they visit, because a lot of times when they are seen, they are given glasses. And even I feel we are doing a disservice in terms of contact lenses also.
Correct,
I
sir.
think a teenager goes for a refract first time glasses, we are always very happy to give them glasses.
Correct,
And they
correct.
keep on changing 6 months, 1 year, and things like that.
Yes.
We never think that probably fitting a contact lens, a primary contact lens,
Yes.
would be a very ideal choice for young teenagers, because it's very easy to get adapted to something difficult as a first time.
Correct,
For
sir.
example, like if people are using cryptok bifocals, when you
Yes.
change them to progressive, they find it difficult.
Correct.
For a first time presbyope, you give progressive, they will have to get used to it because they have no option. They have no
Yes.
comparison. So
Yes.
maybe it is not a bad idea for a very select patient between 12 to 14
Yes.
years or 15 years. A
Yes.
primary contact lens would actually create that self-esteem of being spectacle independent, because whenever a child or a teenager wears spectacles, there is a loss of self-esteem, there is a body image problem, there is some kind of a discrimination, there is some kind of a low on their confidence. So
Correct.
that dependence, once it continues, they start becoming more on the negative side, because the entire society accepts them like that, they are okay that wear their glasses. If a child wants to say at home that it wants to see without glasses, it is not very encouraged by the parents, because there is again a fear that child is seeing well, and
Correct.
why try something which they don't know. And there is a lot of misconception about laser correction. There are so many lasers
Yes.
that are happening. So that is the whole idea. So I
Correct.
think educating public as a whole, and
Is
parents, and as you said, start early in the schools,
yes,
and
sir.
every prescription of spectacle should be followed by that. At the end of the
Yes.
day, at 18 or 20 years, you can undergo a laser vision correction, is something
Correct.
that we need to do. And
Yes.
another point very well made by Dr. Sheetal is, I think the time has come to rethink lens-based procedures, because they are so safe now. Earlier, we had problems with glaucoma because of the sizing. We
Yes.
also had a problem with the wall creating cataracts. Now, I
Yes.
think the sizing of phakic eyeball is so accurate now. Both the problems of glaucoma as well as the cataract are so low in their incidence, and the kind of quality of vision you get in phakic eyeballs is extremely good. I
Yes.
think there has to be some shift of the borderline cases. Instead of trying too hard on a thinner cornea, trying to remove a very high refractive power, it's
Correct.
probably better to probably shift on to a lens-based
Lens
procedure,
based.
and that will probably the future.
Yes.
And maybe a combination, maybe multiple things that are coming in. So That's the whole idea of trying to give a comprehensive refractive solution to at all ages. It's not only for the young, maybe for a presbyope, maybe for a patient with an early cataract. I think
Yes.
making the world spectacle free should be our future goal. I
Yes.
think this webinar has paved a way for it. I
Yes,
think
sir.
people will start now thinking how to make their patients spectacle independent. There are
Yes.
many ways at the cataract surgery age group, at the level of presbyopia age group, but also for our pediatric population, the teenagers. I think it's very important. So I really, congratulate Dr. Sheetal for covering this very difficult topic. Of course, in a very basic way. This is basically meant for young ophthalmologists and the postgraduate students. And thank you, Dr. Meghna, for joining us in this
Thank you,
webinar.
sir.
And of
Thank you.
course, a big shout out to Dr. Namrata Sharma, the lady at the helm of affairs who really planned this whole thing. And she entrusted the job of having this four series webinar. And I thank AOS Scientific Committee for the same and for having smoothly conducted this program and all the viewers for having joining this. And maybe we hope that this will turn out into a accreditation course by the AOS and people can attend, attend to these talks on the AOS website and write some answers to the question and get a certification from the AOS. So thank you so much, all of you.
Thank you, sir.
And
I need to put my credit slide, sir.
you have a credit slide?
Yeah, I need to thank people who have helped me.
Oh,
Just
sure,
one
sure.
second. The
We
last.
will finish with that credits, of course.
So I was just thinking, looking at the magnitude, sir, like we teach them cataract surgeries, no PGs. I think we should start teaching them laser vision corrections because they are predicting that half the population will have myopia by 2050. So
Yeah,
maybe
that's a
medical
business
colleges.
opportunity for ophthalmology also. And also, we should train a batch of people who are very keen to do refractive surgery. We need people to do it.
Yes.
And of
Yes.
course, the technology will catch up soon.
Yeah.
So
And the cost should come down so that I
it
think they should
will.
make
It
it
will. I think it's
more.
if there are
Yeah.
more takers, that is how the business evolves. When the situation
Yes.
becomes more and more prevalent, the cost will come down, and the technology will be more affordable. And
Be-
as the community decides to take up this technology, so I
Yes.
think
Like it.
this webinar will help us to make that shift in the mindset.
Yes.
Hmm?
Yes, sir. So I would, from my side, like to thank the AIOSSC Scientific Committee, particular Namrata ma'am, sir, to you for the inspiration and guidance. And also my PGs who have helped me. We went through the entire low vision set. We kind of had a nice experience with it. And Dr. Meghna Patil also for her
Thank you, sir.
comments. Thank you very much.
Okay, thank you everyone. Thank you, AOS. Thank you, Dr. Namrata. Thanks, viewers, for joining us.